Good evening, and thank you for keeping it TV 47. And of course, this is Body Garage with I, Sheila Chelangat, where you know that here is where your health matters. On this episode, we are focusing on arthritis and fractures. Is it an older person disease, and who is susceptible to it? And so breaking it down for us is Dr. Michael Maru, who is an orthopedic surgeon. How are you, Dr. Ari?
Fine, thank you.
I hope you're doing well today.
I am indeed. Thanks for having me at TV 47.
We are glad to have you. Dr. Ari, let's begin from the top. First, we know it's a disease that affects bones and joints. So what types of joints and bones are this? And then what is arthritis?
Okay, before I define arthritis, it's good to explain the two types of joints that we have in the human body. The human body has what we call synovial joints that have synovial fluid. And then we have non-synovial joints that don't have synovial fluid. The joints that have synovial fluid are the ones that get affected by arthritis. Arthritis is a condition where the lining of the joint wears off and the bone above makes contact with the bone below. The minute those two bones make contact, that is arthritis. And the pain that comes in with arthritis is due to bone causing friction on the bone adjacent to it. So most of the joints in the human body have a synovial fluid. And I wanted just to start by demonstrating what synovial fluid is and what is articular cartilage. This is a human anatomy, and specifically the knee. The area that appears to be white is what we call the articular cartilage. That articular cartilage is made up of very special cells that absorb shock when you're walking, so that bone above there does not cause friction with the bone below, the tibia. That's the femur and the tibia. The articular cartilage is one of the tissues in the body that we know that do not regenerate. Once it's gone, it's gone. Of course, now there are studies and research to try and go back to stem cells and grow articular cartilage. But for sure, we know that once it wears off, it's gone. Once it goes, that is what we call now arthritis.
Okay.
Yes.
And Dr. Ari, this is the human knee. So does it mean it's only the knees that will develop arthritis? Yes.
Most of the joints in the human body have a synovial fluid, just like that. I just chose the knee because they're easiest to demonstrate. But the hip joint, any joint can get affected by arthritis. All the joints in the body, except non-synovial joints. And non-synovial joints are very few. One of them is one where we call pubic symphysis, but they're very rare in the human body. Most of them are synovial joints.
Okay, let's move to, I know there are types of arthritis.
Yes.
Could you mention the types to us, and which is the most common type that affects people?
Yes, there are I would classify them as 5 types of arthritis. We start with the most commonest, which is called osteoarthritis. Osteoarthritis is a condition that comes mainly with age. So in layman's language, we say wear and tear. So it must be a joint that has been used for many years for it to develop osteoarthritis. We don't get osteoarthritis in young people because the joints have not gotten to a point where there's wear and tear. So the commonest age is from about 60 going upwards. So that's why you see people with deformities in the knee, or sometimes they have arthritis in the hip. The commonest joint that is affected by arthritis is the knee joint, followed by the hip joint and the shoulder. So that's the sequence of osteoarthritis. The second type of arthritis is what we call rheumatoid arthritis. Rheumatoid arthritis is an inherited condition. It's a genetic condition that is associated with inflammation of all joints in the body that are synovial joints. So like the knee, the hip, the wrist, and of course the shoulders. That is a condition that is passed on to the next generation. And we know that the inflammation inside the joint results in reduction in the friction, and eventually you get a point where you get osteoarthritis. So the final result, even with rheumatoid arthritis, is actually osteoarthritis. But that condition tends to start earlier in terms of age. It can start in time from about 20s and goes all the way now to old age. The third type of arthritis is what we call septic arthritis. Septic arthritis is a very serious condition because it tends to affect children, so below the age of 15. And it's usually due to pus getting into the joint, and therefore going into the synovial fluid, and then now destroys the joint in a child. That is an emergency, and usually we treat it as an emergency. The fourth type of arthritis is what we call gout arthritis. Again, gout arthritis affects the older population. It's commonly called the lifestyle disease because there's a combination of increased intake of red meat combined with increased intake of alcohol, specifically the lager. Therefore, the uric acid gets retained in the system, and uric acid is then deposited in the joints, and especially around the ankle joint and the foot. That is what we call gouty arthritis. The final type of arthritis, which it's not that common, is chronic or I would just say let's stick to those four. Let's stick to those four because they are the commonest in terms of what we see in day-to-day clinics.
What's interesting, Daktari, is that most of this, of the four that you've mentioned, it's an older, sort of affects the older people. But then there's this one that is in children. What causes it, and why is it that a child would get the arthritis?
Yes, it's common in kids, and it's called septic arthritis, where you have pus inside the joint. It is actually just a spontaneous condition, like the way you'd get a common cold. But now, instead of being a virus, it's caused by a bacteria. Sometimes it can come up because of infection elsewhere in the body. Like if you have pneumonia that is caused by bacteria in a child, that pneumonia, the bacteria in the blood system, what we call bacteremia, the bacteria can then get deposited inside a joint, and now that becomes septic arthritis. So the initial infection was pneumonia, but now presents in with a swollen, tense knee that is full of pus. That is now called septic arthritis.
Okay. And now for this older people, is it just that there's wear and tear? What is the actual cause for the older people?
In the older people, it's a combination of factors. We said one of them is age. And we say age because, you know, the commonest age that is affected is between 60 and going onwards towards 80. So there's an element of wear and tear. The third risk is injuries, because, you know, as you get older, you're likely to have more injuries along the way, and an injury inside the joint can result in destruction of that hairline cartilage. Hairline cartilage is this. Once that hairline cartilage gets destroyed, that friction in the bone results in osteoarthritis. So trauma is one of the risk factors. Yes.
All right. What are the signs and symptoms that normally manifest in someone who's getting arthritis?
Okay, so we'll concentrate on osteoarthritis because that is the commonest of all. We talk about 70% of all the arthritis is osteoarthritis. The commonest presenting complaint is pain. And the pain I've described it is because the bone eventually gets exposed. Bone has nerve endings. So once you have bone rubbing on another bone, the nerves, of course, are sensitive. That's why they get the pain. Before that, this hairline cartilage covers the nerves underneath. So there's no situation where you have that articular cartilage where the nerves can make contact with the other bone, because the articular cartilage is actually a protective layer on top of the bone. So pain is a big complaint. The second complaint that we tend to see is deformities. So like in the older population, you get patients who come into the clinic presenting with bow legs. So they tell you that I never had any deformities in my knees, but for the last 5 years I've noted that the legs are becoming bowed. So that's a common complaint. In fact, there's a man who once presented to the clinic and told me that he's a farmer. He has a few goats in his paddock, and he used to hold them when he was cutting their ears. He would hold them with his legs. The legs became bowed. So they were just coming in and passing through. He could not stop them. He could not hold them with the knees. So, and of course, he didn't know it was arthritis, but so it affected his activities of daily living, because he lived a life of a farmer, and he could not understand why he could not hold the goats between his legs. The third complaint is loss of function. Loss of function is where you find that they come and tell you especially the ladies, they say, I used to be able to walk maybe 100 or 200 meters to the church. Now I can't walk that far because the knee hurts or the hip hurts. I used to be able to bend and pick something from the floor. I cannot do that anymore. So those three core pillars are the ones that we define as arthritis. Pain, loss of function, and deformity. Yes.
You mentioned that there's the most common type. So would you break it down to us in terms of age groups and the gender?
Okay. Yes, we said age group is above 60. Gender, it's arthritis is more common in women than men. Whether I cannot quite tell why, but we think that maybe women present more to healthcare facilities than men. You know, men want to feel tough. Even when they have pain, they don't present. Yes. These are studies that are shown because of the research that is done from the data. But I think women seek medical care earlier than men globally. And that's why it's common. But there's no genetic link that shows that women are more at risk of arthritis than men. Okay.
Yeah. Let's move to the risk factors. Who is more likely to get arthritis? Does family history count? Yeah. What are some of these risk factors?
So, once again, I'll start with osteoarthritis. We said the commonest cause is age. So that one, as you get older, the risk goes up. But now when you come to rheumatoid arthritis, it's now about the genetic predisposition. And once someone presents with rheumatoid arthritis, it's always good to take history and see, was there someone in that family tree, whether the mother or the grandparents, because they can jump one generation and come to the other. So that can be something that is passed on. And especially when you have a lady who has rheumatoid arthritis, the daughters are at a higher risk of getting it, because it tends to go to the daughters.
Okay.
Then when it comes to septic arthritis, we said concomitant infections like pneumonia in kids, or even severe gastroenteritis that is caused by bacteria can go to the knee. So in children, once you get a bacterial infection, it's good to treat it promptly to prevent it going into the joints. When it comes to gout, those who are at risk are people who live sedentary lifestyles, so they don't do any exercise. It's called a lifestyle disease because it's a disease of affluence to an extent. Someone who can afford red meat daily and also afford to have a drink, it tends to be that kind of a lifestyle. So therefore, we advise those ones, we'll talk about treatment, but it tends to be people who just wake up in the morning, get the car, drive to work, sit all day, so the very sedentary lifestyle, and then in the evening then eat. So that the risk predisposing factors. Yes.
Okay. When you talk about arthritis, it's like wear and tear on the bones and the joints. So at what age exactly does it manifest?
We, as I said, the wear and tear can start at any age, but usually we see the symptoms when they're over 60. It can start even at the age of 40s, but you can get a situation where you have wear and tear, but it's not symptomatic. So people come and ask, when do you think this arthritis started? It's difficult to tell because you can take an X-ray. Studies have shown when you take an X-ray of all 40-year-olds, let's say you take an X-ray of the neck, you find that they have arthritis in the neck, but they don't have symptoms. So we talk about when they present with symptoms, not when it started, and it's that age of I would say over 60. Okay,
Daktari, we have gone through the signs and symptoms. We have gone through what causes arthritis, as well as when it manifests. So we take the first commercial break. When we will be back, we'll talk about how to manage, how to treat, how to prevent arthritis. Do not go too far. Thank you for keeping it TV 47. This is Body Garage with Sheila Chelangat, and on this episode we are focusing on arthritis and fractures, and with me is Dr. Michael Maru, an orthopedic surgeon. So Daktari, just before the break we touched on some of the signs and symptoms, the types, and now let's talk about the management and treatment of arthritis. How do you treat it?
Okay, as you said, the first part was about defining arthritis, the types, and we've talked about the age groups. This section, let's concentrate more on once you've gotten arthritis, what can be done.
Yes.
I'll start once again, the next slide. Let's keep together.
Okay. All right. Let's look at the next slide.
Next slide. Yes, that's. This is now the hip joint. Put in a normal hip joint and an arthritic hip joint. So once again, we talked about the articular cartilage. The articular cartilage is a very thin layer, very smooth. This is a normal hip. Once you get arthritis, the articular cartilage starts disappearing. You get holes in the articular cartilage, and that is what is called a worn cartilage. The joint space becomes narrow, and then eventually that bone makes contact with the socket, and now that becomes arthritis. That situation now continues for a period of time. So we talk about mild, moderate, or severe.
Yes.
So mild arthritis we treat with medication. And mild arthritis, someone who is still able to do what they're able to do, but they complain of niggling pain sometimes when they wake up in the morning. So this one is medication and physiotherapy. Moderate arthritis is where it's advanced, but it's not quite advanced to a point where you need to replace the joint. So again, medication, we talk about weight loss, those who are carrying a bit of weight, and physiotherapy, the three pillars. Once you get now to severe arthritis, we are left with no other option than to replace the joint. And the second,
okay,
you can just go to the next one. Yes, we go back to the knee, and as you can see, this is a knee. The articular cartilage is still present in some areas, but once you get arthritis, it's almost like having wounds inside the knee, and that's why they're usually in a lot of pain. Because once you open up, when you're doing the surgery, you open up, you find just bruising inside the bone, where you can see raw surface. That is what causes the pain, and the nerve endings are there. So once it becomes so severe that you cannot, it's not where at the point where it does not respond to painkillers, doesn't respond to physio, and you've done all that, what you call conservative management, then you do now what is called a knee replacement, and that is what has been put there. You come in and take all this layer out. I'm just simplifying it, but it's a 1 hour to 2 hours procedure. You come and take all this, put in a metal component. You come and take all this out, put a metal component underneath, and then in between, you put a plastic insert, so that metal does not sit on metal. That is what is called a knee replacement. If metal sits on metal, you'll get corrosion. That's we learned in chemistry. So to prevent that, there has to be plastic in between, and that's called a total knee replacement. A total knee replacement. Yes. So that is, for the severe one, is now the one that leads to surgery? Yes, for the knee. Then we proceed now to the hip. Again. So luckily I managed to get the implant for the hip. So don't ask me what are these, but they are a method that we'll talk about these implants along the way. But for now, we'll talk about the hip replacement. This is the metal that we normally use for hip replacement. It has a socket that is made of metal, and you can see there. Yes. So that's very similar. And then the socket is made of plastic. Once again, you cannot make a metal a socket that is made of metal because you get corrosion. Yes. So you come into the joint, you take out the arthritic part, cut the bone, put the socket in, and it's held with a bone cement. Cement. Someone told someone cement, they thought it was the concrete cement. Concrete. No, not quite. It's the cement that we use. It's a human. We call it. It's like the cement that is used for dealing with the dental issues, like filling the dental teeth cavities. So similar cement, you put it in, it holds onto the bone, and then you put in a socket. And that's what a total hip replacement is. And from there, the bone does not touch the other bone, and that's why the pain goes away. So people have different sizes of sockets and different sizes of femur. So we have all sizes. So this is for a big person, but of course, once you open up is when you determine what size you're going to put in, depending on the anatomy of that patient. Okay, and that would be able to hold my weight? Yes, that will carry the weight. It's designed to carry a weight of up to 250 kgs. Yeah, 250 kilos.
Okay, that is now for the surgery bit. But now, how can then one prevent themselves from getting arthritis?
Oh, that's a very good question, and we always aim to do preventive medicine instead of curative medicine. Curative medicine is usually quite late. Preventive, first, live an active life. We know that joints that keep moving have a lower risk of getting arthritis. Those who are carrying a little bit heavy weight, we advise that you try and minimize the weight. I know sometimes it's difficult, and it's one of the biggest things to deal with. When someone is overweight and they have arthritis, you tell them to exercise, they cannot do the exercise because they're in pain. So it becomes a vicious cycle. They get more, they continue gaining weight. So losing weight early on helps to minimize arthritis. And then the third one is avoiding injuries. Road traffic accident, sometimes it's difficult to avoid injuries, but for sure, injuries increase the risk of getting arthritis at an early age. Yes. Okay.
And so for someone who's now living with arthritis, what should they look out for? How would you advise them to live now with arthritis?
So we just, of course, we still go back to the type of arthritis. We said septic arthritis in children is an emergency. That one you go straight in. It's usually surgical. You drain the pus and give antibiotics, and that deals with that child. Straight there and then. But for osteo, if you're living with osteoarthritis, you want to see an orthopedic surgeon so that you can go and get a classification. Say, are you in the stage of mild, moderate, or severe? If you're in mild, then we institute the conservative management, losing weight, taking medication, and keeping an active life. If you're moderate, still the same, but at a higher level. But if now you're living with severe arthritis, then you should consider seeing a doctor to decide, should you have a replacement? This is hip, you can do knee, you can do shoulder, you can do ankle. So those big joints can be replaced. The smaller joints, you should do sometimes injections for those with severe arthritis.
Injections?
Injections like steroid injections are still being used.
All right. What about now the diet? For a person who's living with arthritis, how does that look like? What are the do's and don'ts in terms of diet?
Yes, diet cuts across the entire age, and not just for arthritis, even for other conditions. Remember, patients come and ask me, I think my body doesn't have enough calcium. Calcium has nothing to do with arthritis. Calcium has something to do with bone. So bone strength is different from arthritis. Arthritis is about the joint. But having strong bones is what calcium comes in. So balanced diet is important. For those with conditions where calcium is deficient, what we call osteoporosis or weak bones, then you need to take supplements to keep the bones strong. But that has nothing to do with arthritis. Yes. So people can also say, I have severe backache, they have osteoporosis, but not arthritis. That needs to be differentiated.
Okay. And when you talk about physical activity, exercise, what types of exercise?
Okay, we talk about range of motion. So keeping the range of motion. So that's usually done by the physiotherapist. And then the next thing is strengthening exercise, where you have achieved range of motion in any condition, even after surgery. You always want to achieve range of motion first before you strengthen. Because if you try and strengthen, you will damage something if your range of motion is limited. So we get people going to the gym. They want to get muscle. They want to build muscles quickly.
Very quickly.
But they have a stiff joint. So getting them to move that joint to get it flexible enough is the most important thing. And then strengthening exercise. Strengthening is about power, strength building. So those two.
Okay, let's move to now someone who is living with, the arthritis pain. Is there a quickest way of getting rid of that pain? And then what should they do or what should they not do when they are having that pain?
Yeah, the quickest remedy for arthritic pain is, of course, medication. And we classify medication into a pain ladder. So depending on how severe the pain is from 1 to 10, you can take those medications that are on the lower level, like paracetamol. it will get rid of the pain. But as arthritis gets severe, you may need to use what we call anti-inflammatories, which are more stronger. So a combination of something like paracetamol and something like diclofenac or cyclophenac. So those are now higher level. And then eventually sometimes some patients require things that have opioid derivatives in them, like beta pain, but that's now advanced arthritis. So it's good to know where you are in that ladder, and it can only be determined by going to see a doctor, getting an X-ray. By the way, the way you decide whether it's mild, moderate, or severe is an X-ray. So whoever is out there who thinks that they have arthritis, the first thing you should do is to go see a doctor to get an X-ray to confirm indeed whether it's arthritis, and if so, what stage of arthritis are you at.
And I do not know if it's a myth, Dr. but some say that, you know, when you're having that pain, you should probably consider hot and cold therapies. Is that a viable option?
Yes, anything that you can do to reduce the pain is always good. People come with all sorts of stories. There are those who live in cold areas. When it's cold, the pain goes up. That can be explained because when you live in cold areas, especially you have issues with your knee, like arthritis, the body tries to conserve heat by putting the blood back into the central system.
Yes.
So that process of conserving heat makes the nerves more active. But others say they feel better when they lie on there are all sorts of things like nougat beds, those hot mats that come from abroad, and then some ladies are so religious about it that they feel that unless they go there once a week, the pain will never go away. The heat treatment is a very good thing because heat always reduces the pain mechanism. So it helps, but it's a temporary measure. If you have severe arthritis, you can keep doing that, but eventually a replacement is what sorts it once and for all.
Okay, and let's talk about another myth, which is, you know, cracking knuckles.
Yes.
Can it lead to arthritis?
No, it doesn't. The cracking knuckles, especially fingers or even the knees, some people come and say every time they get up from a sitting position, people ask, it's so loud that it can be heard across the It's usually due to ligament stretching. It is not anything to do with the lining of the joint. That's why you're able to do that. The ligaments, after staying in one position for too long, once you stretch them, they make that noise. The only time you should be concerned is if that cracking noise is associated with pain. Then go see a doctor. But make noisy knees and noisy hands, it's okay. And live with it.
Now, for the next part, we would be dealing with fractures. And I would want you to talk about, is there a correlation between arthritis and fractures? Now that it affects the bone, then am I, you know, susceptible to get fractures?
Yes, the only correlation between a fracture and arthritis is actually the other way around, that a fracture can result in arthritis, but arthritis does not necessarily result in fracture.
Yes.
Because a fracture is a broken bone or a broken bone. If a bone breaks in, and I may use this, inside the hip, maybe you should go back to the knee one. To the knee. The anatomy.
This
or even
one. This one.
That one, yeah. So if you get an injury, and we know we have talked about this, especially in motorbike border riders. The mechanics are that they're sat with their knee bent. Yes. The part that makes contact with the road or another car or another object is the knee. That's why you get a lot of injuries in younger patients. You get knee injuries. Yes. The minute you get a fracture here, it damages the cartilage there. It can damage at an early age as 15 or 20. By the time you're getting to 30, he has developed arthritis, not because of old age, but because of trauma. Okay. So fractures can result into arthritis in later life or even in middle age.
All right. Yeah. Dr. We are up for our second commercial break. When we will be back, we will talk much more about now fractures and what can be done to prevent them. Do not go too far. Keep it TV 47. All All right, welcome back and thank you for keeping it TV 47 and of course Body Garage, where on this episode we are focusing on arthritis and fractures. And just before the break, Dr. you had hinted on fractures. So what is a fracture and what causes a fracture?
A fracture is a break in a bone. So as I said, we have more than 240 bones in our bodies, and any bone can get broken. So when you get a break in the bone, in medical terms, we call it a fracture. So patients come in and ask me, is it broken or is it a fracture? It's one and the same. And a fracture occurs in any bone, can occur in any bone in the body, including the skull. Yeah.
And what actually causes those fractures? What causes a bone to break?
So we classify fractures into the causative aspect of it into two. There has to be some energy, high trauma, or a fall. For example, when you fall, you can get a break in the bone because of the force that is exerted on that bone. But there's some fractures that occur without necessarily there being a force.
Yes.
Those kind of fractures occur in patients who have weak bones. The commonest cause of weak bones is osteoporosis. So patients who have osteoporosis, they can just be getting up and they get the bone can break, especially the spine. Then the other group that gets fractures easily are fractures that occur where there's cancer. So if bone has been eaten up by cancer cells, it can break very easily. So those are, we call them pathological fractures because they've happened in a bone that is not normal. But in normal bone, getting a break, there has to be some impact. So that's why I brought this picture here just to demonstrate that this is the knee joint. You can see this is a bone called the femur. This is a bone called the tibia. This is a bone that is called the patella. And this is called the fibula. So that's a knee joint. And up there is a hip joint. So this is a high energy injury. So it's broken the femur into two. This should be in continuation with this. So that is what we call a fracture. Yes.
And you've mentioned that sometimes it's because of weak bones. This weak bones, is it because someone lacks calcium?
Yes. Let's just talk about osteoporosis as one of the causes.
Yes.
Osteoporosis can occur, especially at middle age. It's more, once again, it's more common in women because we know that during the period when the women get to menopause, that alteration in hormonal aspect of it can result in reduction in bone density. So osteoporosis is more common to women for that reason. Then it's not that they don't have enough calcium. They may have enough calcium, but that mechanism of calcium metabolism changes during that period after postmenopausal. So those kind of patients who are predisposed to that, then they need to be on supplements to ensure that the bones are strong enough not to get brittle bones that break easily.
And when someone has now a broken bone, do they know that this bone is broken? Are there bones that you would probably not feel them broken?
Yes, I said, if you try and classify the two groups, you say there's high impact and no impact. There's a no impact at all. Those ones I said are pathological, where a bone can break without you knowing. You just experience pain. Some patients also get what we call stress fractures, especially the runners, because the bone has this repetitive injury for such a long time, the bone breaks without them knowing. But for this one, for sure you'll know you've broken a bone.
Yes.
Because there'll be pain, there'll be deformity, and of course other associated factors that you'll know you have a broken bone.
And in the event that now a bone has broken and that I do not know or I do not feel the pain really, what would happen to me eventually?
It's unusual. You'll get some pain. It might not be as much as like this high impact. Like this patient is a patient who most likely like a road traffic accident. The commonest cause is the knee hitting the dashboard.
Yes.
People, those who are not belted up, and I must say that using a seat belt is one of the most important things that you can do to prevent fatal injuries as well as now fractures. So you will feel the pain, but for those who don't have, they'll have some pain. Eventually, once you know they stay with it, a few weeks down the line, they say, this pain is not going away. So go and do an x-ray, you find that there's a healing, there's already a fracture that has started healing, and you know they must have broken it at that time. That also happens.
Okay. Now, on the table, I can see some of the, I want to say metal.
Yes.
What are they for? And I assume, is it for treatment?
Yes, these are the, I brought in some assortment of the metals that we use to treat bone. But before we get to this, we need to classify fractures into two.
Yes.
The first group is what we call closed fractures. A closed fracture is where a bone breaks but does not come out of the skin. So you can get an injury where, like the thigh bone, where the thigh gets hit like by a dashboard. It breaks, but the bone stays inside the skin. But the second one is called an open fracture, where the bone hits and comes off the skin.
Yes.
Like in motorbike injuries, because motorbike injury, the mechanism is that the leg makes contact with the concrete, with the tarmac, and the bone comes off. Open fractures are usually treated using what people call aerial. It's called external fixator. So you put screws into the bone. I don't have a specimen of bone here, but you drill. This is a drill bit that we use. So this is a drill bit that you use to drill through bone. You drill to the bone. You put these wires coming out of the skin, and you put bars to hold the bone together. Because if you try and put that bone back in the you close the skin, you'll get infection. Because bone has made contact with something that is not clean. It could be grass. Sometimes you find somewhere on muddy places. So once you open up, you find there's grass inside the socks. So that has to be clean, and you put this area, what you call external fixator. The second group, which we call closed fractures, is where you use this kind of implant. So I brought in some metal here. This is the biggest metal that we use. Of course, they come in different sizes because we have different sizes of the femur. That's a bone called the femur. This is specifically made for the femur, and it's that metal in there. So once you get a broken bone, we go through the bone marrow. This is the bone marrow. The bone marrow, that's where that metal is. You drill at the top here.
Yes.
Once you drill at the top, you open up. So you open up the socket up there, access the bone marrow, and then once you access the bone marrow, you check the size of the patient. You need to drill through. Some people, of course, are taller than others. Others are wider, so they come in different sizes. And once you determine that this is the size that fits that patient, you go in and put it in. Then you pull this leg, because if you don't, if you allow it to heal this way, you have a short leg.
Okay.
So to prevent someone having a short leg, this bone here must come here. So there's usually some pulling that has to be done. Then once you get it aligned, you push this metal through to achieve that. So that now you achieve the length.
Okay.
So in the process you achieve what we call the length, rotation, and alignment, so that that leg comes back to normal. If, for example, it's not done correctly, you'll have a short leg, or one leg will be walking with the leg. So some situations where it's done badly, for one reason or another, you can find someone walking with a leg that is pointing outwards, and that's deformity that can be corrected just using this tool. Yes, this other one is for the lower bone called the tibia. Again, they all come in different sizes, and it's molded to fit how the bone looks like. And then this higher one here is for the humerus at the top here. They all come in different sizes again. So that is what we use for long bones. So we classify bones into long bones and short bones.
Yes.
Yes, these long bones, we use these rods, put in the bone marrow. But now, in areas where you are close to the joint, like now if you get a fracture here, there's a joint here, so you cannot put a rod like this. We use plate and screws. So this is the plate and screws, and I must say that all this shiny metal is stainless steel. It is not silver. As one of you thought, because it's shiny.
It's very shiny.
Yes, it's stainless steel, so that it doesn't corrode, it doesn't get rust. And these are metals that have been tried and tested in the human body to a point where you can say the body will not react to this foreign material, because it's foreign material.
Yes.
So this is now for it's a big metal for a fracture around here. So you put it in, you align it, and then you put screws. So it has holes that allow you to put as many screws as you need to if you have a fracture here. So this sits on the bone inside the skin, not outside the skin. Then you have the areas where you need small. I think this is for the wrist. As you can see, it's quite small.
Yes.
It's a very common injury around here. Putting screws. This is as light as it gets because it's titanium. Titanium is obviously more expensive than stainless steel, and it's also more expensive than the cobalt chromium. So for big bones, they require this heavy metal. But for smaller bones, it's titanium.
The small ones.
Yeah.
And once you put the metal inside the body, are there those that are removable?
Yes.
And are there those that now will remain there forever?
Yes, in children, you must always remove the metal between 6 months and 1 year, because people who have not reached skeletal maturity, they're still growing. If you don't remove, the metal will be swallowed into the bone, because the bone is growing.
Yes.
And you'll never get access to that metal again. Unless you break the bone. So that's why we remove them before the age of, after 1 year. 6 months to 1 year after putting it. Once the bone has healed, you remove metal in children. But in adults, because you've reached skeletal maturity, you don't have to remove the metal unless it causes issues like prominent metal or recurrent infection, or situations where people say when they go to cold areas, they feel that they have the metal, then you remove.
And how long does it take for one to heal after such a procedure?
Yes, we'll talk about the biggest bone in the body, which is the femur. That's the biggest bone in the body. This takes 4 months to heal once you put this. And then the smaller bones take 2 months. So it's a period of between 8 weeks and 16 weeks. But in children, less than 10, the fractures heal quicker. So 4 weeks to 1 month to 2 months, most of the fractures are healed.
Okay.
I must say, not all fractures are treated with metal. Some fractures where you get a broken bone and it has not moved out of position, you put a plaster, what you call the plaster of Paris or Dynacast. So you mold it and you hold it with a plaster for that period of time and it will heal. So you don't necessarily have to put metal in any broken bone.
Any broken bone. All right. And for someone now who probably has undergone the surgery, or someone who has the plaster, how would you advise them to look out for themselves so that they heal properly?
Yes, that's a very good question. Once you put in the metal, like what we've done there, the next thing that you want someone to do is to keep the joints moving. They don't necessarily have to bear weight, but a physiotherapist must attend to that patient. If you don't keep the joint moving, the joint will become stiff. So you'll have a very well-healed bone, but a stiff joint.
Yes.
So this joint must continue moving. That's why you fix the bone to go for early mobilization. That's the reasoning behind fixing the bone. In the old days, like 30 years ago, the only method of treatment that there was traction. So someone breaking a bone like this, they will be put on traction, they're in bed, the leg is pulled and some stone is put at the side there, like 5 kgs, to pull that, and they would stay like that for 4 months. The bones used to heal, but one of the complications was stiff joints because they were not moving their joints. So now we fix them so that they can start physio early.
And perhaps the last question, Dr. How then can one prevent themselves from getting these fractures?
For high impact injuries, avoid accidents.
Yes.
They're
unavoidable.
Yeah, some of them are unavoidable, road traffic accident. But the ones that you can avoid, avoid falls. But for those with weak bones, get supplements so that the bones can become stronger, like in osteoporosis. Those with weak bones due to cancer, get it treated so that the bone can be strong enough to avoid fractures, what we call fragility fractures that occur due to low trauma.
Okay, and perhaps someone is watching and wondering, where can I find Daktari, and maybe your last parting shot on this as well.
Okay.
Yes.
I'll just say thank you very much for inviting me to come and talk about fractures. It's a big topic. Of course, we've covered just the tip of the iceberg. We can discuss more next time, but I hope that we've given an overview of arthritis and fractures. For me, I said my name is Dr. Maru. I have a clinic at called Nairobi Spine and Orthopedic Center at 40 Suits, Hospital Road near Kenyatta National Hospital. And I also go to PCA Kikuyu Hospital on Thursday mornings. Yes.
All right. Thank you very much, Dr. for shedding light on, arthritis and fractures. And I do hope that back at home you have at least grasped 1 or 2 things on arthritis and fractures and how you can prevent them. And if you're living with them, on how you can live better with it. Thank you for keeping it TV 47 and Body Garage every Thursday. It is a pleasure having you. I am Sheila Chelangat. Do have yourselves a lovely evening.